Welcome to our Retrospectroscope digital story, The Journey of Recording Blood Pressure. In this 30-minute video, we hope to reveal the historical principles and methods used to record blood pressure, highlight key individuals that developed new methods and instruments, identify the fundamental questions answered with these inventions, and finally explore the emerging questions and frontiers of innovation. Ultimately, we want to illustrate how scientists construct instruments to answer questions that they have, and how they explore the unknown with tools that they currently possess. So in this first half, we'll cover the history of blood pressure measurement until modern day. Our journey begins with early Greek philosopher Aristotle and Roman physician Galen. There was quite a bit of controversy surrounding the heart's function and anatomy. Many, including Galen, thought that the heart was two-chambered until Andreas Valesius noted that the heart had 4 chambers and not 2 after studying real corpses. Aristotle and Galen's influence held fast for 1500 years. In particular, Galen had a theory postulating that blood was constantly produced from the liver and consumed by tissues, and that wasn't challenged until 1628. Through William Harvey, this fundamental question was answered: how does blood move through the body? Having observed the heart in living animals, Harvey believed that blood was moved by the heart, not the lungs. He was an English physician that researched the mechanics of blood flow, and he performed many experiments and heart dissections on various animals, all aiming to uncover the physiological design of the circulatory system. One of Harvey's teachers, Fabricius, who discovered the presence of valves in veins, propelled Harvey to later discover the unidirectional flow of blood. Prior to Harvey's findings, it was generally believed that blood was produced from digested food and consumed by tissues, and many physicians believed that the lungs moved the blood or that blood was being constantly consumed in the periphery, or in other words, not circulating. His initial calculations showed that the blood being issued from the heart in any given moment in time was far too much for tissues to absorb. Through further mathematical analysis, Harvey concluded that the blood passing through the heart in a given period was greater than the amount contained in the whole body, and these observations challenged the validity of the previous knowledge. So thus, through mathematical calculations in his work, Harvey was able to prove that it was not possible for blood to be consumed by the tissues. And as mentioned previously, Harvey studied animal models. When he removed the heart from a living animal and it continued to be acting as a pump and not a sucking organ, this led him to conclude that the blood must be going through a circulatory system, composed of arteries and veins, in a series of rhythmic contractions going in some sort of cycle. After Harvey established that the heart worked as a pump, the next logical question was, how strong is this pump? To answer this question, Stephen Hales was the first to measure blood pressure with a number. Hales was an English clergyman with a primary interest in botany, biology, and physiology, with a focus in quantitative experimentation. In his work, Hemostatics, he performed a wide range of physiological studies on a variety of animals, with his most notable work on quantifying the force of blood in a horse. So why was he so interested? Well, the discovery of the circulatory system raised questions about the force of blood exerted on the blood vessel, and this postulation led Hales to invent the first blood pressure instrument. Consequently, he also made the first direct measurement of blood pressure. The first direct blood pressure measurement, also known as direct manometry, was carried out in 1733 in a horse by Hales. An open-ended copper tube was stuck directly in the artery, and if Harvey was truly correct about blood being pumped and a force being produced, then blood, like any fluid, should rise up within the column and exert a force against atmospheric pressure. Thus, the height traveled by the blood gave an approximation of blood pressure. Using Harvey's findings and the pre-existing fundamentals of pressure, Hales found that the height traveled by the fluid reflected the force of the blood exerted on the arteries.
After Hales described blood pressure in quantitative terms, the next concept to tackle was how can we qualitatively measure blood pressure to create a more holistic picture. At the time, percussion from the thorax was foreign to physicians and the potential of relating cardiac pathologies to heart rhythm was unknown. This was due to the fact that the only way to listen to the heart was direct ear-to-chest auscultation. To resolve this problem, René Lévesque invented the stethoscope, allowing doctors to hear and describe auditory abnormalities in pulmonary and cardiovascular conditions. René Laennec, a renowned French physician in the late 18th to beginning 19th century, was famous for his work in the field of pathological anatomy. During his time at Neck Hospital in Paris, he revolutionized the field of medicine with this invention and immediately applied it in clinical settings. Using simple principles of sound conduction, Laennec designed a hollow tube with a plug at the end to provide a pathway for sound waves to propagate towards the listener's ear. No longer do doctors have to press their ears to patients' chest. They can now use this instrument to obtain clear audio of heart rhythms and blood circulation. While the invention of a stethoscope does not appear to be directly related to blood pressure measurement, it is really important to note that this tool was necessary for the invention of the modern sphygmomanometer that will be discussed later. Just as Laennec refined the methods to examine the chest, Jean Poiseuille revisited the fundamental research question of what is the force of blood, and invented a mercury manometer to measure blood pressure while establishing the common unit of blood pressure reading that is still used today. Jean Poiseuille was a French physicist and a physiologist in the mid-19th century who had a keen interest in understanding the physics of blood circulation, which led him to perform countless experiments involving the flow of liquids through a narrow tube. Recall earlier that Hale's method of blood pressure measurement involved measuring the rise of fluid in a vertical column. Although there were great advances, the normal arterial pressure required an average column height of 8 feet to record. If only there was a way to condense the apparatus. Well, there is. The liquid manometer is a U-shaped tube with two ends, usually exposed to different pressures that is used to determine unknown pressures. In Poiseuille's manometer, one end would be exposed to the atmosphere while the other was attached to a cannula that is directly inserted in an artery. The difference in fluid height represented the pressure that the blood is applying to the system. Instead of using water, mercury, a denser liquid, was found to be a great substitute as it allowed the manometer to be more compacted, and the difference in height can be recorded using a smaller tube. The creation of the first mercury-based manometer for blood pressure, termed hemodynamo, allowed for more efficient measurement of blood pressure. This also laid the foundation for the use of millimeters per mercury as a universal unit when describing blood pressure. Prior to Carl von Weerholtz's invention of the sphygmograph, blood pressure was only able to be measured invasively. His invention solved the question of how blood pressure could be measured non-invasively. Who was he, you may ask? Carl was a German physiologist in the 19th century who devoted most of his time to quantitative analysis of blood circulation, such as velocity of blood flow and blood pressure. Before von Weerholtz's time, the advances made in blood pressure measurement were unprecedented but clinically impractical, as the needle had to be directly inserted into a patient in order to measure it. Carl von Weerholtz noticed the relationship pulse had with the state of blood circulation, and he utilized the principles of counterpressure and Newton's concept of equal and opposite forces to create an apparatus to measure blood pressure in a non-invasive way. These ideas were applied with this thought. If a pulse represents the force of the blood acting on the arteries during systole, then the counterforce needed to suppress a pulse will be equal in magnitude to this force of blood. This principle manifested into an invention dubbed the sphygmograph. The method of this blood pressure measuring instrument was quite simple. The radial artery would be compressed with increasing weights until the pulse of the patient could not be detected. The corresponding pressure applied to achieve this would signify the systolic pressure. The transition from an invasive to non-invasive method represented a great leap in clinical medicine. Despite its lack of clinical use due to its complicated setup and accuracy, its principle remained the foundation for current sphygmomanometer.
Weerholtz's sphygmograph was refined through the invention of a mercury sphygmomanometer by Scipione Rivarocci. This design would give rise to modern-day blood pressure wrist cuffs. Scipione was an Italian internist, pathologist, and pediatrician who is known for his work in devising this non-invasive method for measuring blood pressure. Weerholtz's apparatus suffered from inaccuracy issues due to the limitations of using solid weights for pressure measurement. However, by recalling another method of measuring pressure, the mercury manometer, we can see how Rivarocci was able to combine these two resources to create the cuff-inflated mercury sphygmomanometer. As a matter of fact, he combined the principles of von Weerholtz and the technique of Jean Poiseuille to construct this device. The method of this instrument is as follows. The cuff is wrapped around the arm and inflated until the radial pulse is suppressed. Then, pressure is slowly released until the pulse can be faintly detected. At this point, pressure is determined by the height of the mercury in the vertical glass tube. When we pair an accurate measurement tool like this mercury manometer and combine it with the counter-pressure principle for non-invasive quantification, we get a viable tool for clinical practice. It's important to note that the modern instrument for systolic blood pressure measurement still relies on the principles and ingenuity of Scipione's mercury sphygmomanometer. 9 years later, a Russian surgeon also used a combination of previous inventions to create a new technique that could reliably and accurately measure systolic and diastolic pressure non-invasively. This man was called Nikolai Korotkov, and he developed a standardized method to properly assess blood pressure through auscultation. Korotkov was a Russian military surgeon during the Russo-Japanese War. In his research on maintenance of blood flow in traumatized limbs, he came across a series of distinctive sounds in his observations with a stethoscope and the Riva-Rocci cuff we just discussed. He found that some of these sounds corresponded to systole and diastole, allowing these measurements to be taken in real time. His technique was under scrutiny by skeptics for many years before it was globally accepted in 1939. To make these measurements, the cuff of a sphygmomanometer was wrapped around the patient's upper arm and inflated to cut off blood flow. A stethoscope was placed on the blocked artery, and pressure from the cuff would slowly be released. The pressure that was read from the sphygmomanometer when the first sound was heard and when the sound stopped were representative of systolic and diastolic pressure, respectively. The ingenuity of Korotkov's technique was that it was not only non-invasive, but easily reproducible. This method is still used today as the standard technique for measuring minimum and maximum blood pressures. As the medical field progressed, new techniques to measure blood pressure needed to be invented to provide continuous information during surgery, where the prevention of hypotension, clinically low blood pressure, is very important. Improving on previously established catheterization techniques of Carl Ludwig, a man by the name of Sven Seldinger provided a continuous, real-time blood pressure measurement along with the ability for arterial blood sampling. This Swedish radiologist invented a way to insert a catheter into any artery for use during operation procedures. This allowed for timely and accurate identification and treatment of hypotension. As such, this technique has lasted until the present as a gold standard in continuous blood pressure measurement and arterial blood sampling during surgery and perioperatively. To use an arterial catheter, a 5-step approach is used. First, the insertion site is selected. Some common sites include the radio, brachial, or femoral artery, with the radial site being the default. The length of the catheter is also selected to reduce risk of dislocation during surgery. There are many techniques to then properly insert the catheter, but all of them involve inserting a needle at a 30 to 45 degree angle to the skin, as seen in this diagram. First, the artery is punctured with a needle that is then pushed upwards to insert a leader. The needle is then withdrawn and the artery compressed. The catheter is threaded onto the leader and inserted into the artery. Finally, the leader is withdrawn and the catheter is properly in place. In the next step, the catheter is calibrated for accuracy by zeroing the pressure transducer. This is required because pressure readings will depend on the body position of the patient. Finally, the quality of the blood pressure waveform can be checked, and if everything is in order, you are now able to continuously obtain blood pressure measurements from the patient. Today, this technique is used for required continuous blood pressure measurement in anesthetized patients and critically ill patients with circulatory shock. It is also used for intermittent arterial blood sampling and advanced hemodynamic monitoring. Now that we're all caught up in blood pressure recordings for the past 400 years, we're going to discuss what is awaiting us in the future.
So what does the future of recording blood pressure look like? The first emerging technology that we will discuss are automatic and home ambulatory blood pressure monitors. These monitors provide blood pressure measurements that have only recently become available, and with increased data on hypertensive patients, the definition of hypertension has begun to change. Let's take the example of Arnold Schwarzenegger. According to the Body Mass Index for men, he's considered obese with a BMI of 31. Clearly, however, Arnold is not obese. Like Arnold and the body mass index, the definition of hypertension is outdated. With increased understanding of vascular diseases and technology that measures far more than blood pressure alone, the definition of hypertension has shifted from the classic over 140 systolic and 90 diastolic blood pressure to something far more complex. There has been a shift in the paradigm of blood pressure measurement. Research and diagnosis of vascular diseases has shifted from making one blood pressure measurement in the office to multiple measurements over the course of the day. Enter automatic ambulatory blood pressure monitors. The principle of these monitors follow the same principle as Krotkov's auscultatory technique. However, it differs in that it is programmed to measure arterial blood pressure at specific time intervals over a 24-hour period and can be worn and used throughout the day. The goal of this technology is to evaluate lifestyle factors such as physical activity, location, position, mood, and whether you are asleep or awake, and their effects on blood pressure measurements. A good example is physical activity. During physical activity, blood pressure increases. In hypertensive patients, intense, maximal activity can be dangerous as blood pressure can get too high. On the flip side, exercise is recommended for these patients to lower blood pressure in the long run. Thus, submaximal activity programs have been administered, and the effectiveness of these programs require blood pressure monitoring outside of the office. So how do patient participants measure this situation during a blood pressure measurement? Recall, the things that they have to measure during a measurement are situational factors including physical activity, location, position, mood, wakefulness, and other factors of interest. There are two ways to do this. The first way involves an observer who records the time of day and situation. This is often used for children, elderly with dementia, and the illiterate. These patients or participants must be institutionalized or in a limited space. The second way involves self-report of personal and environmental factors. This method requires detailed education on the procedure. For example, diary entries must be made immediately, not take a substantial amount of time, and capture the factors of interest to the study. In addition, if blood pressure measurements are made every 15 minutes, diary entries themselves should not take 15 minutes, or else the participant's situational factors would always just be them writing. Recent research has also shown that electronic diaries that capture situational factors increase compliance of this self-report method. Now, let's move on to home blood pressure monitors. Like automatic ambulatory blood pressure monitors, home monitors require proper education on their use and provide information at specific periods of the day. In contrast to automatic ambulatory blood pressure monitors, home monitors mainly measure blood pressure multiple times in succession in the morning and at night, and after medications are taken. The advantages of home monitors include higher accessibility and freedom from observer errors and other causes of inaccuracy with auscultatory measurement. So let's summarize emerging question number 1 about the changing definition of hypertension. Recall, these measurements have only recently become available and are not currently part of diagnoses of numerous vascular, hypertensive, and hypotensive diseases. That being said, data from these monitors have been used in diagnoses of a small number of vascular diseases, including white coat hypertension, masked hypertension, morning surge, nocturnal hypertension, and numerous others. Overall, these measurements provide out-of-office measurements not previously available and are changing the definition of hypertension and vascular diseases in the future. Here's the second emerging problem. What blood pressure measurement should we use during surgery to improve post-operative outcomes?
A promising option lies in real-time, non-invasive measurements. So let's give some context. First, it must be noted that blood pressure measurement is important in every surgery. Second, let's recall the two most common methods. One is the invasive technique, using an arterial catheter, which provides continuous, real-time blood pressure monitoring. It is highly accurate and the current gold standard in continuous blood pressure measurement. The other is the non-invasive oscillometric technique, based on Korotkov's oscillatory concept. This technique is convenient, safe, and reliable. It provides measurements every interval, usually every 5 minutes. Moving on to the limitations, the arterial catheter is limited by the fact that it's 1, invasive, causing trauma to the patient. 2, can be put together incorrectly, putting the patient at high risk. And 3, it is infeasible in patients with certain vascular or concurrent diseases. Non-invasive techniques are limited as they 1, lack accuracy at extreme hypo or hypotension, and 2, make measurements every 5 minutes, which leads to late recognition and delayed correction of periods of hypotension, and misinformation on the depth and time spent in these same periods. So why do these hypotensive periods matter? Well, these hypotensive periods are associated with postoperative complications in a time dose dependent manner. Time, referring to time spent in hypotension, and dose measures the severity of the hypotension. Common postoperative complications of hypotension include myocardial infarction, stroke, and kidney injury. In addition, patients with specific vascular or concurrent diseases are at risk of other complications. For example, in the POISE trial, patients with a history of cardiac and peripheral artery disease suffered increased stroke mortality in comparison to controls when performing surgery with hypotensive periods. So what's the solution? Remember, the problems are that invasive measurements are, well, invasive and infeasible for some. And non-invasive measurements are inaccurate at extreme blood pressures and miss hypotensive periods during surgery. Enter continuous, non-invasive blood pressure measurement, of which we will discuss one method, the volume clamp. The volume clamp method. The principles are as follows. The volume of finger arteries are assessed using infrared photoplethysmography. Next, using a fast-reacting inflatable pressure finger cuff, blood volume is held constant in the finger. The pressure of the finger cuff needed to maintain constant blood volume is thus proportional to the blood pressure. However, this means that only precise changes in blood pressure are measured. This method is only accurate at 0 transmural pressure from inside the blood vessel to the pressure of the cuff. If blood pressure measurements of other body parts are required, then output of the finger cuff must be mathematically extrapolated to determine the blood pressure of the area of interest. In addition, the volume clamp can also cause venous congestion distal to the probe if the cuff pressure is higher than venous pressure. This can be unpleasant for the patient and is infeasible in patients that can't tolerate venous congestion, such as in patients with Raynaud's syndrome. A product that prevents venous congestion in acral parts of the body is the CNAT device, which uses multiple finger cuffs that alternate in continuous non-invasive blood pressure measurement, avoiding prolonged venous congestion. So how does continuous non-invasive blood pressure measurement improve postoperative outcomes? There are 3 ways. 1, it is a non-invasive procedure that limits trauma to the patient. 2, it provides continuous, non-intermittent blood pressure measurements to patients unable to use an arterial catheter. And 3, it can predict hypotensive periods before they occur, improving correction times. It seems perfect, right? Unfortunately, there is a second large barrier to using volume clamps. The risks of hypotensive periods during surgery are not negligible, but are severely outweighed by other factors during surgery. So it's not a prioritized risk factor. In addition, recall that arterial catheters provide blood sampling and gas analysis, which are impossible for non-invasive measurements to provide. Therefore, currently, volume clamps are not a replacement for arterial catheters, but it can improve blood pressure measurement in patients that can't use arterial catheters. In fact, studies have shown that when Nexvin volume clamp and Korotkov's intermittent non-invasive measurements are used simultaneously during surgery, the clamp captures 6 to 8 more minutes of hypotension during 1 hour of orthopedic surgery. In addition, CNAP's volume clamp showed similar results in cesarean sections. And in thyroid gland surgery, using CNAP decreased time spent in hypotension by 20% and increased blood pressure stability. It's also important to note that these clamps provide measures beyond simple blood pressure. It provides info on arterial curves, beat-to-beat analysis, and numerous others. These extended measures are factors that are being clinically researched to determine their association and impact on postoperative outcomes. Soon, diagnoses of many vascular diseases will change as more research is performed. So extra, by 2050, researchers predict that blood pressure measurement will be the news. It will be non-invasive, easy to use, wireless and wearable, and of course, smart. In addition, it will provide real-time information on blood pressure, including the arterial pressure curve, arterial elastance, and could even administer fluids like vasopressors. So as this technology increases, the depth and availability of knowledge pertaining to vascular diseases will increase. In turn, definitions of hyper and hypotensive diseases will change. Blood pressure monitoring will become more widely available, and treatments will continue to become more personalized to each patient, improving health outcomes.
Thank you for watching our Retrospectroscope story. We hope you enjoyed, and if you have any questions, feel free to email us at the email listed above, and we'll try to get back to you as soon as possible.